Two general surgeons finished the same 5-year residency on the same Tuesday in June. 6 years later, one of them does the same 6 operations every week: gastric sleeve, gastric bypass, hiatal hernia, 3 more sleeves on the same Wednesday. The other one does 41 different operations in the same week alone on a county hospital schedule that fills itself by Sunday night. Both of them still call themselves general surgeons. Only one of them still practices the full breadth of general surgery. The fork between them happens on one Wednesday morning in November of chief year. The room holds 12 senior residents and a fellowship application portal open on a laptop screen. Level 1, the intern. $66,000 a year, 80-hour cap weeks. July 1st, you walk into the hospital with a real medical license. It lets you write orders, pronounce death, and run a code if the senior is in the bathroom. You got here through surgery clerkship in 3rd year, a sub-internship at the program you wanted, and Step 2 CK in the spring. 2 away rotations through the summer, plus letters of rec from the chair, and 1 senior attending. General surgery is still one of the few residencies in the country that fills almost entirely with U.S. medical graduates. You matched into it. 5 a.m. alarm, pre-round on 3 or 4 post-op patients before table rounds at 6:30. Pager attached to your scrubs. Epic. Haiku open on your phone. The day is owned by floor work. Discharges, drain pulls, consults, family meetings the senior wants to skip. OR time is 1 or 2 laparoscopic cholecystectomies a week as second assist. You hold the camera. The senior drives. The attending stands across the table and watches. 3 a.m. on a Wednesday in November. The pager goes off. Post-op fever on the 7th floor. You walk the hallway alone and run the workup before calling the senior. 4:20 a.m. the same morning. Intensive care unit, Bay 3, first central line. The senior watches over your shoulder. The needle goes in clean. The following Tuesday afternoon, a 91-year-old on comfort care stops breathing while you are at the bedside. Time of death noted. Family called. Paperwork signed by 5 p.m. In the elevator the next morning, a family member asks who you are. You say, "I'm a general surgery intern." The phrase already feels like it belongs to someone else. The OR booking sheet outside the surgeon's lounge has 11 cases on it for the day. Your name is not on it yet. You read it anyway every morning before pre-rounds. 4 years from today, a 47-year-old farmer with perforated diverticulitis rolls into the trauma bay at 2 a.m., and you are the one calling the attending at home. You don't know that yet. Level 2, the junior resident. $70,000 a year, 2 years into residency. Loops purchased. They sit in the locker in their case until you remember to bring them out. Intern year is over. You sat for fundamentals of laparoscopic surgery in the spring. ATLS card in the wallet. By the start of PGY3, the American Board of Surgery requires at least 250 operations logged. 4:45 a.m. Night float covers the trauma bay. The day junior covers the intensive care unit and the elective OR. Your name appears on the OR booking sheet for the first time. 3rd line down on a Tuesday morning. Laparoscopic cholecystectomy. Primary surgeon, you. The patient is 42. Delivery driver, 3 years of biliary colic. The attending sits in the corner with her feet up. The senior is in another room. You drive the camera. You dissect Callett's triangle. The cystic duct gets clipped, then the artery. The gallbladder peels off the liver bed and comes out through the umbilical port in a specimen bag. You close the port sites yourself. 48 minutes door to door. The attending stands up, says "nice job," and goes to grab coffee. The delivery driver walks out the next morning. Lap appy on a teenager Wednesday afternoon. Open inguinal hernia on a retired electrician Friday morning. Trauma bay 6 on Saturday night. A stab wound to the left chest. Oxygen saturation 88 on arrival. You place the chest tube. The senior calls the chief. The case list on the lounge bulletin board is filling up, but the cases on it are bread and butter. Choles, appies, hernias, simple breast biopsies. The thoracic cases your attending did in residency are not on the sheet anymore. The vascular cases used to be, the pediatric cases used to be. None of this is a choice you will make for another 3 years. The narrowing only becomes obvious in hindsight. The photo of the OR booking sheet you took on first lap chole morning is still on your phone 2 years later. You scroll past it sometimes without recognizing it as something you wanted to remember. 2 more years, and the trauma bay is yours to run. Level 3, the chief resident. $80,000 a year. 5 years in, chief year started July 1st. The American Board of Surgery requires 850 operations across residency and 200 in the chief year alone, 48 weeks acting as the chief across PGY 4 and PGY 5. The qualifying examination, the written board, sits on the calendar for late October. 4:30 a.m. You run morning report at 6, you own the service list. The pager comes to you first, the attending comes to you second. The OR booking sheet outside the lounge has your name on 3 of the 5 lines. Thursday morning. Whipple, pancreaticoduodenectomy, as primary assistant on a 68-year-old retired teacher. The hepatobiliary attending stands across the table. You make the duct to mucosa anastomosis under her gaze. It is also the only Whipple you will do as a trainee. Friday morning, open thyroidectomy as primary surgeon. Right hemicolectomy as primary the following Monday. Mastectomy with sentinel node, biopsy on Tuesday. AAA exposure with the vascular service on Wednesday. You open the retroperitoneum. The vascular fellow takes the clamp. 2 a.m. that Friday night, a 47-year-old farmer with perforated diverticulitis rolls into the trauma bay. Lactate 4.2, white count 23. You are the one calling the attending at home. You take him to the OR by 3:30 a.m. The contamination is everywhere. You wash him out, take down the perforated segment, end colostomy, leave the abdomen open. The attending is in the room by the time you close. She says, "Your call from here." You manage him in the intensive care unit for 6 days. He goes home on a Thursday. November of chief year. Fellowship application season opens on a Monday morning in a workroom on the 4th floor. 80% of graduating general surgery residents now pursue fellowship. The chief on the next service signs a community hospital contract that week for $500,000. You have not finished filling out your colorectal application. Same residency, same Tuesday, match week in June, and completely different jobs at 38. You tell the farmer's family at the post-op visit that you're a general surgeon. They thank you. 3 weeks later, you click submit on the colorectal fellowship portal at 11:20 p.m. in your apartment. The phrase is true and almost over at the same time. 90 days to the fork. Level 4, the fork. July 1st arrives. 2 senior residents from your class drive to 2 different cities. They will not see each other for 15 years. Path A, the fellow. $90,000 a year. You matched into MIS through the Fellowship Council in March of chief year. July 1st, you walk into a new institution as the most junior member of a 4-surgeon bariatric and foregut group. 1 service, all year. 5:30 a.m. No floor scut. The residents do that now. You operate 4 days a week. Monday morning, Roux-en-Y gastric bypass on a 51-year-old machinist. Monday afternoon, sleeve gastrectomy on a 43-year-old accountant. The senior partner who taught you the bypass technique walks past in the hall and asks if you have done any open AAAs since June. You have not. Tuesday, hiatal hernia, repair on a 60-year-old with 8 years of reflux. Wednesday, ventral hernia, reconstruction. Thursday, sleeve gastrectomy. The same 5 operations on the same anatomy for 12 months. The lap chole you could do in your sleep on graduation day is gone in 5 years if you do not maintain it. Nobody told you this in November. Fellowship year ends in June. You have not done a thyroid, a breast, a hemicolectomy, a AAA exposure, or an open inguinal hernia in 14 months. The bariatric and foregut cases on your sheet are at the top of the field. The other half of general surgery is now someone else's job. Path B, direct to practice. $500,000 a year, guaranteed for 3 years plus $80,000 in loan repayment over 5. You signed in March, state medical license through reciprocity, board eligible after the QE. 6:30 a.m., 8-minute drive from your house to the hospital, 25 beds, the only general surgeon for 60 miles. Endoscopy block, in the morning, OR block in the afternoon. ED consults on top. 1 and 2 call from day 1. Monday, lap chole on a school principal. Tuesday, open inguinal hernia on a contractor with a year of dragging discomfort. Wednesday, breast lumpectomy with sentinel node on a 5th grade teacher. Thursday, portacath placement on a colon cancer patient before he drives 90 miles east for his first chemo cycle. Friday, total thyroidectomy. 2 a.m. Saturday morning, a 47-year-old farmer with perforated diverticulitis rolls into your ED. Same lactate, same white count. You take him to the OR by 3:15 a.m. You open the abdomen alone, control the contamination, pack and close temporarily, ship him to the intensive care unit. The transfer center 60 miles east calls back at 5 a.m. and asks for a copy of your op note. You write it on the call room desk in pen first and type it into the EMR at 6. The OR booking sheets outside the 2 lounges look completely different already. The fellow's sheet has 4 hepatectomies and a Whipple on it for the week. The rural attending sheet has a chole, a hernia, a breast, an EGD, a port, and a thyroid. All the same. Tuesday. 5 years into the job, both surgeons sit for the same oral board in the same week. Level 5. The junior attending. $450,000 a year, junior attending, 2 OR days a week, 1 clinic day, 1 admin day, tumor board on Thursday morning. The certifying examination. The oral board comes at the end of fellowship or in your 2nd year of practice. 3 examiners, 3 rooms, 90 minutes of cases. You pass. The 2-step ABS sequence is over. You are board certified for life. 6 a.m., the inbox has NSQIP outcome reports from the prior month and 2 patient portal messages from overnight. Your name owns the outcome on every case from now on. Monday morning, sigmoid colectomy on a 53-year-old elementary school principal with diverticular stricture and 3 prior bouts of diverticulitis. You take the segment, anastomose, close, and send him to the floor by 11 a.m. Post-operative day 5 at 2:30 a.m. the floor pages. Heart rate 130. Abdominal tenderness. CT shows extraluminal contrast at the anastomosis. Leak. You are in the OR by 3:40 a.m. Down comes the anastomosis. Up comes a colostomy. You wash out the abdomen, leave a drain, close. The principal goes back to the intensive care unit at 5:50 a.m. He will keep that colostomy for 9 months before reversal. M&M conference the following Wednesday at 7 a.m. Your case on the board. The room is full of partners, 2 of whom trained you. The chair walks the slides, you walk the decisions. NSQIP flags the case in the inbox by Thursday. In clinic the following Monday, a patient asks what kind of surgeon you are. You start to say, I'm a general surgeon, and stop mid-word. You finish with fellowship trained in colorectal. The phrase has already changed shape. Tuesday, anti-reflux fund application on a 49-year-old physical therapist. Wednesday, laparoscopic right hemicolectomy on a 68-year-old with an obstructing cancer. Thursday, tumor board at 7 a.m., 3 lap choles in the afternoon for a partner who is on vacation. The case list outside the lounge has 9 operations on it on a Tuesday. The number of lap choles on your monthly schedule shrinks year by year. You do not track it. 5 years into practice and the same patients start showing up on your clinic schedule. Level 6. The mid-career attending. $550,000 a year, 12 years out from match week. 2 partners in the practice are people you helped train. ABS, continuous certification cycles every 5 years. You attended your first 10-year research prep course the previous September. You are now in the chair across the table from the Residency conference. 6:30 a.m. The OR booking sheet outside the surgeon's lounge has the same 6 operations on it every week. Anti-reflux fund application on Mondays. Sleeve gastrectomy on Tuesdays. Paraesophageal hernia repair on Wednesdays. Bariatric again on Thursdays. The same scrub nurse for 8 years. A Monday afternoon in clinic. A new patient walks in with right lower quadrant pain and a CT report in his hand showing diverticulitis at the sigmoid. He sees your face, smiles, and says, "Doctor, you don't remember me." You read his chart, Laparoscopic cholecystectomy. 10 years ago. October. You were a PGY3. He was your fourth lap chole as primary surgeon. Gallstones, biliary colic, 42 years old at the time, a delivery driver. He came back to the office 2 weeks later and told you his wife appreciated the home-cooked dinners again. You have not done a sigmoid resection in 9 years. The man gets walked across the hall to the colorectal partner before he leaves the building. The colorectal partner sees him at 3:30 p.m. the same afternoon and books him for surgery the following Tuesday. 2 weeks later, the colorectal partner stops you in the hallway and asks if you can do a lap chole for him on Thursday morning. One of his patients, gallstones. He has not done one in 7 years. You and your partner across the hall used to be the same person. The colorectal cases go to him, the bariatric cases stay with you. The lap choles, breast biopsies, and small hernias bounce between you depending on whoever has block time on Thursday morning. In the elevator on the way down, a med student asks what you do. You say, I'm a foregut and bariatric surgeon. You used to say, I'm a general surgeon. The day you stopped is gone from your memory. 10 more years pass, and the rural surgeon on the other side of the state is still on the same call schedules. Level 7, the Endgame. Endgame A, the chair. $800,000 a year base plus a department administrative stipend that takes total compensation past $1.2 million. Department chair at year 20, post-fellowship. FACS, American College of Surgeons Board of Governors slate. 3 visiting professorships last year. Operate Mondays only. M&M conference Wednesday at 7 a.m. You run the room now, hire junior faculty, Tuesday afternoons. ACS committee calls on Thursdays. You sit on the search committee for the head of surgical oncology. Monday morning, laparoscopic right hepatectomy on a 58-year-old retired engineer with a single colorectal metastasis. The hepatobiliary fellow stands across the table. He makes more of the parenchymal transection than you do. 2 p.m. on a Tuesday in October. The trauma service pages you. Damage control laparotomy on a 50-year-old after a motorcycle crash. They need a senior set of hands. You walk down to the trauma bay and look at the open abdomen on the table. You tell the trauma fellow to call the acute care faculty instead. You have not packed an open abdomen in 15 years. You have not done a lap chole as primary surgeon in 5 years. Endgame B, the aging rural generalist. $650,000 a year, same town, same hospital, same OR, same scrub nurse for 22 years, 1 and 2 call for 3 decades. 6 a.m., the same 8-minute drive. The OR booking sheet has 11 different operations on it for the week. Midnight call, a pneumothorax in a 40-year-old logger trapped under a falling tree on the highway. The thoracic surgeon would have placed the chest tube. But the thoracic surgeon is 200 miles east. You place the chest tube. 2 a.m. the same week, a breast abscess on a postpartum woman who is 6 days out from her first delivery. The breast surgeon would have drained it. The drainage goes to you. Wednesday morning, a lap chole the colorectal partner used to do at the academic center. Except there is no colorectal partner here. The case is yours by default. 2 a.m. Saturday morning, the same farmer from your first year as attending, only he is 69 now. He has come back with a small bowel obstruction from his old colostomy reversal. The transferring family asks who's operating. You pick up the phone in the ED bay and say, I'm a general surgeon. You are the only person in the conversation for whom that phrase still means what it used to mean. The mean number of surgical generalists per 100,000 Medicare beneficiaries was cut in half. The number fell from 105 to 50 between 2000 and 2021. Half the generalists in the country are already gone. There is no recruit behind you. The closest general surgeon to your west is 200 miles, also alone, also 61. The OR booking sheet for next Monday has 9 cases on it. You know all 9 patients by name. Monday morning, 6:30 a.m. in 2 cities 600 miles apart. The fellowship-trained foregut and bariatric surgeon pulls into a covered garage at the academic medical center. The OR booking sheet outside the lounge has 6 operations on it for the day: sleeve, bypass, hernia, sleeve. anti-reflux. The same 6 he did last Monday, the same 6 he will do next Monday. The rural generalist parks behind the single-story critical access hospital on the other side of the country. The OR booking sheet outside the surgeon's lounge has 11 different operations on it. His name is on every line. Both of them finished the same 5-year residency on the same Tuesday in June, 22 years ago. Both still call themselves general surgeons. The bariatric surgeon will not do a thyroidectomy, a breast lumpectomy, or a hemicolectomy this year. The rural surgeon will do all 3 before the end of the month. His name is on every line.